Welcome everyone to today's webinar, Aligning for Change, Driving Quality Performance and Risk Management with AI. On behalf of Becker's Healthcare, welcome and thank you for joining us. Before we begin, I'm going to walk through just a few quick housekeeping notes. If you have any questions throughout today's webinar, you can type those into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you have trouble with the audio or video, please try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. And with that, I am thrilled to introduce today's wonderful speakers. We are joined today by Krista Hoagland, CEO of Security Health Plan of Wisconsin, Dave Henriksen, COO of Trinzic, and Vice President of Clinical Operations of Castell, an Intermountain Healthcare company. And our moderator, Dr. Erin Neinstein, Chief Medical Officer of Notable and practicing endocrinologist at UCSF. Krista Hoagland is a key proponent of Security Health Plan's strategic imperative, calling for stewardship of financial and human resources. She is highly focused on reducing the total cost of care for Security Health Plan customers and across the health insurance and healthcare industry. As Chief Actuary and Financial Officer, Krista was a key leader in cost reduction efforts at Marshfield Clinic Health System, through which Security Health Plan achieved more than $80 million in year-over-year savings. She has shaped policy, planning, and analysis, guiding the health plan's decisions that affect its financial performance. In fact, she recently served as a witness at a U.S. Senate Finance Committee hearing on marketing in the Medicare Advantage sector, after which CMS included excerpts of her testimony and new rules to rein in marketing practices and broker compensation. Krista has worked closely with the financial leadership team at Marshfield Clinic Health System to ensure financial vitality for Security Health Plan and the health system overall. Dave Henriksen serves as Chief Operations Officer of Trinzic, a physician-led, clinically integrated network of more than 1,000 primary care providers. Dave is also Vice President of Clinical Operations for Castell, an Intermountain Healthcare company, leading the company's efforts to operationalize value-based clinical care models. Dave brings many years of experience in clinical operations at Intermountain Healthcare to his role, as well as targeted leadership in advancing Intermountain's understanding of value-based care. He has been integral to the early success of Intermountain's value-based care model called Reimagined Primary Care, having led the development and implementation in clinics across the health system. Prior to Intermountain, Dave managed outpatient surgical clinics at Kaiser Permanente in Portland, Oregon. Dave received a Master's of Healthcare Administration from the University of Minnesota. Krista and Dave, thanks for joining us. And with that, Dr. Neinstein, I'll turn it over to you.
Awesome. Thank you so much, Sarah. So as Sarah mentioned, I'm Erin Neinstein, Chief Medical Officer at Notable. Super excited to kick off the webinar today. We really do have two people who I personally look up to learn about the value-based care space, and in particular, how organizations are innovating in value-based care. So Krista and Dave, thank you so much for joining me. We're really going to dive in today on how organizations like theirs can use AI and automation to drive quality performance and risk management. And what's fun about doing this in the value-based care space, I think, is the need really to drive both top-line revenue, lower cost of care, improve outcomes in a really profound and meaningful way. So I want to dive in by just allowing both of you to share a little bit about your organizations so the audience can get to know Security Health Plan and Castell. So Krista, we'll have you start off here and tell us a little bit more about Security Health Plan, some of the history there, and high level, some of the work you're doing there.
All right, that sounds great. Happy to be here. Thank you for having me. Erin, it's always great to sit down and chat with you, and happy to have Dave along for the ride today. It should be fun. So just a little bit of background on Security Health Plan. So I've been the CEO for about 2 years, but have spent most of my career there. It's part of the Marshfield Clinic Health System, and we serve central, northern, and western Wisconsin, so a regional health system. We believe we're one of the oldest rural HMOs in the country, being in business for more than 50 years. So that's a pretty remarkable amount of time to serve the rural market that we serve. We have about 225,000 members spread across that region, served by a little over 500 employees. And we really serve kind of all lines of business. Our intent has always been to serve the needs of the community. And the needs of the community, right, require different things at different stages of life. So we've always had that robust product portfolio, willing to serve folks, whether they're in Medicare, Medicaid, individual, or a commercial plan, as well as operating a small self-funded back office function as well. We're really engaged in our communities, both financially as well as through our time. So we measure that both through time and treasure, but really consistently try to contribute financially to our communities. We are very focused, as our many regional health plans, on quality. So measured by CMS stars, we're currently at a 4-star, but we typically have been a 4 to a 4.5 star throughout our history. Also highly rated by NCQA and Medicaid ratings as well. And then something we think really does distinguish us is our focus on customer service and really taking care of our members. And we look at it not just through the lens of how others in healthcare are delivering on service, but really measure ourselves more broadly. And again, I think this really has differentiated us. We think about customer service as you would experience it from those that are top, in the country or in the world. And it's resulted in quite a few awards for us. And again, it's something we hear over and over again from our members, that they feel like they can call us for anything. And we're always there to help and support them in their healthcare journey. And then finally, being part of an integrated health system, we are certainly very focused on those customers that are shared. So we have about 100,000 that are also patients of our integrated health system. And so as we get into more of that value-based care discussion, and particularly how we've leveraged technology, that's been a space, I think, where we've made the most progress, as you would expect, and really have probably the most to share, with that integrated health system lens.
So, Krista, thank you so much for that overview about Security Health Plan. Dave, would similarly love to kick it over to you to have you share a little bit of an introduction to the audience about Castell and what you would do there.
Sounds great. Thank you, Dr. Neinstein, and thank you, Krista. Pleasure to be on here with you today. I'll maybe take a minute and talk a little bit about Castell. Castell's a little unique from certain or most entities that you might think about in the healthcare space, but we're ultimately Intermountain Healthcare's population health company, here to help both employed and affiliate providers enter into as many value-based arrangements as we can. We do that across multiple payers and products, and really try and consolidate those on behalf of the practices we work with. And then the second piece is to help them perform in those value-based arrangements. So really want to provide the tools and resources necessary in order to help those clinicians become successful. So Castell at a glance, just kind of getting a feel for where we are and some of the lives that we're serving and what we're doing. Intermountain has grown in the last little bit as we've merged and or acquired a few different medical groups or health systems, and into Montana, Colorado, and Nevada now, where we've traditionally only been in Utah and Idaho. About 1.2 million lives under management. We have about 600 employees, and pretty split across employed and affiliate providers that are in and part of our network. A little bit of the history. I think it will be helpful to kind of understand where this comes from, but Intermountain was started in 1975. The Church of Jesus Christ of Latter-day Saints decided they did not want to be in the healthcare business anymore and divested their assets and created a not-for-profit health system, which is Intermountain Healthcare, with the mantra of working to be a model health system. And so 1983 turned on Select Health, our own health plan, with the intent of really trying to keep costs and prices down. And in 1994, launched the medical group for the same purpose. And then really our population health journey kind of kicked off in 2011. And we've kind of been on that really ever since. And we launched Castell in about 2019.
Awesome. So thank you both for those introductions and sharing about your organizations. Diving right in, would love to talk about, there's obviously a really big difference in where automation is needed in a volume-based fee-for-service world versus a value-based care world, really unique operational and financial challenges. And Krista, maybe I'll start with you. You've got a background in financial performance and policy. You just spoke in front of the Senate Finance Committee at the United States Senate. Can you talk a little bit about your perspective on the unique challenges that the plans face as you think about shifting to value-based care?
Yeah, I think this is a really important sort of baseline question, right? In our experience, I would say a couple of things immediately come to mind, which is the most important thing is to find a willing partner. As a payer on your own, you can not drive the transition, right? The providers really have to be engaged and interested, and I think that's foundational. There has to be that interest, and then you have to meet them where they're at. Which for every provider entity is a different place, and be willing to, make that journey with that provider system unique, and customized to, their willingness to sort of move along that risk continuum. Building trust and being transparent are incredibly important as part of that sort of foundation, because at the end of the day, if they don't trust you, right, if they don't trust your data, they're not going to be willing to continue to move along that continuum. So, we think those are tremendously foundational. And then, being prepared to set up those data feeds. We have so much rich data within the plan, and I think it's easy to forget that providers don't have that. They don't have that sort of 360 view of every claim, right? Every encounter that a patient has had. And so sharing that and then helping them understand where their opportunities are really is, something else that is incredibly important. And then helping the system, right, the provider system, engage their providers and bring them along. So it's one thing, right, if the entity is supportive and interested in moving along the value-based care continuum, but if the providers are not invested, if they're not seeing value from their perspective, it's going to take you a lot longer to get to those important success metrics. And so, as we talk more and more, it is, how do you get the providers? How do you make it easy for them? Because if you can make it easy for them to do what you want or what they need to take care of their patients, they're going to get on board so quickly. And so that's another one of those foundational things that I think is really important as you're engaging in this with those providers.
Yeah, it's so true. I think I've shared with you as a practicing physician how I feel about the letters I get from plans saying, do you think that this patient should go on a statin? And they send me a letter in my snail mailbox, and it goes into the shredder. So really appreciate your perspective from a plan side on the importance of trust and engagement with providers. Dave, from your perspective, you shared the history of operating this really large value-based care organization. What drove the urgency and need from your perspective for AI, for automation within Castell's operations? What was challenging as you look back a few years and made you feel like, oh my gosh, we can't keep doing what we're doing here. We need to do something different?
Yeah, I think one of the curses and blessings that we had getting started in a mature integrated delivery system was that there were a lot of lives already on the table, right? That we needed to support and take care of. We have our own health plan and other payers who had started to line up with this. So for us, it was more about scale and speed, and ability to actually get the number of caregivers needed in order to be able to operationalize the things that we had tested and tried over a year or two prior. And frankly, our systems are not designed really well. They're great for fee-for-service interventions, but doing value-based care kind of feels a little bit like swimming upstream with a lot of the platforms and tools that we get. And so that was really the impetus for us to really try and look to AI or RPA to really help us be more efficient in what we were doing, or we weren't going to be able to perform in all the lives that we had just kind of started.
Were there particular places that felt like they were the most manual, the most cumbersome? Where did you have the most waste or inefficiency that you saw?
Yeah, there's probably too many to count, and there's still plenty to go. But I think we have a key role in our organization called a care coordinator. And a care coordinator does a number of different job functions, including coordinating care, as you would think, but also does a lot of pre-visit planning and care gap closures, annual wellness visit scheduling, some huddling with providers. And I periodically try and get out and see what teams are doing and what it looks like. And so joined for a half a day or so watching one of our care and was just shocked at how manual their work was in order to get the things done that we needed to do. And in particular, care gaps were a pretty big bottleneck for us in taking the majority of a care coordinator's day. And really, that was a lot of cleanup. So stuff that was sitting in claims, stuff that was sitting in non-coded data, stuff that's in PDFs or faxes, and really not in a place where a caregiver or clinician could do something with it, and also trust what the EMR was surfacing to them. And so that was probably one of the big areas, Aaron, that we noticed early on. The other two that are probably really massive as well is, we take delegation from payers for care management, and part of that is you got to be NCQA accredited and follow those standards and guidelines, which are pretty rigid on what needs to be done. And because we have a completely remote workforce, which we love for all of the reasons from hiring to efficiency and all of the pieces that we learned over the pandemic, we were completing a lot of these things over the phone, which was taking people up to an hour, depending on who you were working with doing those intakes. And so saw a need to make that more efficient. And then the other kind of labor intensive resource we deploy is making sure that we capture appropriate acuity of our populations and make sure we have accurate documentation and coding with our clinicians as they take care of their patients. And it was very manual, used lots of humans in order to be able to validate that certain codes need to be captured, or that there was a previous condition that they had and over time it's been missed, and how do we get that in front of the clinician? Those are kind of the three areas that we felt like we had the most opportunity and the most waste as far as time spent, and could be more efficient.
Yeah, those are great. It sounds like, to put it lightly, is a target-rich environment for efficiencies.
There's plenty to do. I think we've only scratched the surface, that's for sure.
Would love to have, maybe starting with you, Krista, think about, as you over your career have worked with technology vendors, what influences your thinking as you enter into a partnership? What are you looking for in a relationship? What makes a technology healthcare organization partnership successful in your opinion?
Yeah, I mean, yeah, having worked in healthcare for many years, as Dave highlighted, there's no shortage of mistakes made, right? As you're thinking about partnerships, as you're exploring, there's so many out there that truly I think we've learned through mistake, right? How do we find the best partners for ourselves? So for us, it starts with really understanding what our need is first. I think it's hard when you engage in conversations and you're not clear about either what problem you're trying to solve, right? Or, what is the optimal kind of look and feel of the solution. So I think that's really, really fundamentally important, that you don't kind of come in casually with, well, let's hear your pitch, right? Knowing these are major issues that we face. These are major opportunities that we have. And then, being open to listening and hearing. I think I'm not a huge fan of a traditional sort of RFP process and pitting folks against each other, because I don't know that always gets you the right answer, right? It may get you the best price. But to your word around partnership means something different. It's about trust. It's about working through problems together to get to solution, as opposed to, I need you to, I'm going to give you this money and you need to give me this product. Being somebody that's willing to iterate with you and know that we might not get it exactly right the first time, and that's okay. Let's work together to incrementally improve. And so I think those are, a few of the things that we really think about when we're engaging with a technology partner. I also think it helps when, like Notable, you guys have access to such tremendous talent that would be really difficult for us to hire on our own. And so that talent pool that you can bring to the table. Also, I'll never forget sort of sitting down in our first conversations with you all. And I know how smart your people are, but watching the faces of my team and seeing, what Notable can turn around for a demo, right? Or an example to say, is this what you're looking for quickly? I think really, really helps to get folks engaged and excited. And then the rest of it, seems to take care of itself.
I love that. And, I would say right back at you, I think what's really important and meaningful is when it's a good fit, right? And when the expertise of the two partners, fit together like puzzle pieces. And so, have really appreciated working with the expertise that your team has as well. Dave, over to you. Thoughts on what makes a good partnership, what you look for. You've worked with lots of different technology companies. So what are some of your learnings?
Oh, I think probably the biggest one I would say is that we need flexibility. We've got lots of platforms out there, lots of different EMRs, and in some respects, we feel like we've constructed our own version of our own technological Frankenstein to help us get our work done. And so as we're evaluating partners, almost all will, promise and say that they do seamless integration and that it's all connected. Not sure that's always panned out for us, maybe to Krista's point of some missteps and some things that we've learned over the years. So I think we're looking for a partner to help us creatively solve problems that others have not. To Chris's point, an RFP actually doesn't even work in this space because it's not a commodity. We're not doing RFPs for architects or contractors. We're trying to figure out stuff that's been the same way for 100 years, and we're trying to flip it or change it. And so not everybody speaks the same language and is trying to accomplish the same thing. So I think it is pretty health system specific. And so, a partner really kind of helps us sort through all of that.
It's fascinating hearing you guys talk about this because I mean, RFPs are pretty standard and commonplace in the space, and hearing so strongly from both of you that they fail to really support, how to find the right partner, I think is a really interesting insight. So yeah, thank you for sharing. So I know you're both at different stages in your partnership with Notable. Security Health Plan is much more recent. Castell and Notable have partnered for several years. So, Dave, starting with you, would love to hear you talk a little bit about some of the outcomes we've been able to achieve together. And then Krista, we'll turn it over to you to talk a little bit more about how you're thinking about the work we're doing together. And as you were talking about driving engagement among providers, care teams and patients, how you're thinking about that going forward. But Dave, let's start with you.
Yeah, and may pull up a slide here to help tell the story with some visuals. I think, to highlight some of those areas, Aaron, that we noticed as low-hanging fruit, lots of manual labor, things that needed to be optimized, care gap chart review, attestations, suspecting, care management outreach, and enrollment in various programs that we're working to get our members to participate in. It's a lot of work, and it takes an army of people to do it. I think, you look at some of the cost savings and FTEs that are created, as we've partnered with Notable on this, those are real, right? Those are FTEs that we didn't have to hire as we moved forward, scaling our operations across all of our plans and products. And I think kind of an interesting anecdote that we're working through, Dr. Neinstein, around the FTE capacity created. That's just a snapshot in time. And it's been pretty interesting. We've been doing that for a couple years now. And what we're starting to see is that we've actually kind of cleaned up the EMR and cleaned up our patients' records, which we thought might not ever be possible. And so actually the capacity we're creating is smaller because they're actually not even doing as much of that work anymore, right? It's cleaned up. Care gaps are cleaned. Up to date. Annual wellness visits are scheduled for next year already as they go and see their PCPs. So, we're continuing to collaborate with Notable, trying to say, okay, well, what's next, right? Like, great, we tuned up that piece. There's a lot of other stuff that we've got to go tackle and address, but patients are really satisfied with it. The team members are really happy to use it, and on the care program enrollment, I would maybe just comment a much higher program enrollment rate than what we were getting from doing our own things. And this is to really engage in diabetes solutions or mental health solutions or the digital front door type solutions. So it's nice to have a partner to help us do that.
Yeah, I mean, these outcomes are amazing. So proud of the work we did together. And going back to the previous discussion about RFPs and finding partnership, and your point about we've cleaned up the first round, and so now it's the next opportunities, right? Like, it would be really tough to go do another RFP for another commodity versus saying like, well, what's the next thing, and what's the next thing, and what's the next thing. With that level of flexibility becomes really important.
Yeah, agreed.
Krista, so turn it over to you. I think Security Health Plan had a slightly different set of goals and needs, although obviously in a very related space. How are you thinking about the work we're doing together to drive higher engagement?
Yeah, so I look forward to the day when I have a slide like Dave's to share in a setting like this, and I do think we're going to get there. But yes, we're in a very different place. Just really rolling out earlier this year some of the work around HCC and quality gaps. And I think the reason why that's sort of been the initial focus is we did recently have a new system implemented for our care delivery system, and that has created, not the greatest data. And so it's really, again, I can't wait to get to where Dave's at and saying that all this stuff is cleaned up, but we're sort of at the front edge of it's not clean. We've got a lot of unstructured data and it's not allowing us to take the best care of our patients. And so that's what I'm most excited about. We're really doing all this work to surface some of the unstructured data that's hidden within the EMR that tells us, hey, they don't have a quality gap, right? That's actually already been taken care of. We don't have to inconvenience the member and ask them to come in again. They've really already been taken care of. Or to use that data to say, oh, but they have a different gap, or there's a concern, right, from something that we're pulling out of, a lab or some other such thing that then is positioned so that the physician doesn't have to go searching through it, right? Doesn't have to read potentially, right, thousands of pages of information to understand how they can best help. Whether it's identifying they have this condition, let's code for it, let's make sure that our revenue matches the risk of this patient, but also so that that's factored into their care treatment plan, right? So we're really taking optimal care. And the key, as I've highlighted, is how do we make it easy for the physicians, right, to do their job? They want to take care of patients just as much as we do. And so, that's really the place we're at right now is the physicians are starting to get used to having, these prompts, this additional information. They're learning to trust it and say, okay, yes, that's right. Now I'm going to click this button, right, to either code it or, schedule whatever follow-up or whatever necessary. And so, that's the first piece. But we also know we've had a lot of conversations around sort of chatbot, virtual assistant. How do we make it easy for our members to get information from our website, to self-serve, even perhaps to dig into, their specific information sort of, behind those portal walls, because we think there's tremendous opportunity there around them not having to call in for customer service to get something answered, and rather being able to tap the data that rich data that's already out on our website. And so that's the second thing that we're going to be quickly following as soon as we feel really good about, sort of the first launch, focused around the care.
Amazing. So, one of the things that's challenging from both of your roles, right, from Castell, from Security Health Plan, is that you are not directly in the care delivery organization. And so I imagine as you're deploying things like this, there are change management, communication challenges and strategies and tactics that you have to take. Krista, starting with you, and then Dave, how are you thinking about change management with your care delivery organizations, with your providers, as you deploy these technologies into those spaces?
Yeah, this is a critical component. As you can imagine, right? You can have the greatest technology in the world, but if people don't understand why or how, right? If you haven't brought them along through the change management process, it's ultimately not going to bring you the value either at all, or it'll take you much longer to realize it. So this is another thing.
How do you avoid the digital equivalent of Aaron throwing the statin reminder in the shredder?
Yeah. Right. And so it really is about engaging folks early, right, in the process. So how do you make sure that you haven't made a decision, right, done an implementation, and then folks are hearing about it? So we have, and again, we have many, many lessons learned from, having maybe not done it as well on other implementations. But we have been working sort of side by side with our provider care delivery system on this notable journey, and that's helped a lot. We've still found spots where we haven't done it as well. I had the pleasure of recently going through a change management class, and had this sort of reminded. I love the ATCAR model for change management, and that knowledge to ability gap. So remembering that a provider may know, right, they may understand what they need to do, what they're supposed to do, but it's going to take them a while for it to become sort of embedded right in their process. And so, we'll have to likely do a lot of education ongoing until it becomes sort of second nature for them to do it. And they really have flipped into that. They have the ability, not just the knowledge of what they're supposed to do. So that's something that we're going to continue. And I think we'll learn a lot within Security Health Plan about how to better help our provider system implement. And so when we go right for the next thing, when we move along the list to our next endeavor, we'll be better prepared to implement more successfully on the next iteration.
Yeah, and Dave, how about at Castell?
I think many of our leaders in Castell, and including myself, actually come from medical group backgrounds, right? So working either administratively or seeing patients in the clinic, and so we have a pretty good feel for the flow and kind of how things work and what day to day looks like. And while I totally agree with Krista, we're trying to be as transparent as we can about what we're doing. To me, the best change management is no change management, in that it's so clean that they don't even know that it was done. And I think that's what we really kind of strive to do is, what are you doing in your regular workflow? What are you doing in your standard process every day? And how do we provide tools and resources that enhance that workflow or make it easier to do what you're already doing? It's so hard to get people to go out and click in other places or order in other places or find other things that's not part of what they do every day. And it's time consuming and it's frustrating. So to the extent we can, we really try and partner to come up with solutions that feel as seamless as possible to our patients and to our clinicians. Doesn't always work, but there are a lot that you can do as you integrate with different EMRs.
Is there an example of that comes to mind where you implemented something that felt so seamless people didn't even really know it was there?
I mean, the care gap work is certainly part of that, right? So, Notable used kind of the RPA tool, go out and search for care gaps that need to be closed. They'd find them, surface them, we'd update them and change the problem list for the provider with the appropriate advisories or recommendations firing. And the clinician didn't know that happened. All they know is they walked into their appointment and they've got a pretty clean advisory list of the gaps that need to be closed. And they're not.
And no blowback from the medical group on that.
No blowback. In fact, people are pretty happy. Those visits go faster. They're easier. I mean, you're no longer having the conversation about, hey, we need to take a minute and talk to you about getting your mammogram. And the patient's like, I got that 3 months ago. Like,
so
how come you don't know that?
Kind of like disappeared off of their plates. And
yeah,
because I mean, so, like I talk to a lot of people and they do, I think before they go down this journey, they do worry, like, we're going to have to get buy-in from the physicians and they're not going to like it. So it sounds like your experience was, if you're taking work seamlessly off people's plates, they didn't complain.
That's right. Makes it a little bit easier from that change management perspective. And for those that we did require some change, there was such substantial time savings in what they were doing that they were willing to make those adjustments, right? And change what their standard work or their flow looks like in order to get the outcomes that we thought we could get. And that's a nice part too about I think working with a partner, is that, like, we could do small tests of change first before we, did this massive wide scale, contract across the board. And it's, well, can we show that it works first and test it and trial it and have some of that data so that when you go and have to do some of that change management, you've got more than we just need you to try it or trust us. There's some good experience and use cases which make it really nice.
So one last question I want to throw to both of you before we turn it over to audience Q&A. Dave, let's start with you, and then Krista. Looking forward over the next 1 to 2 years, obviously AI is moving very rapidly. What are you most excited about that you believe AI can unlock for you? Some opportunity that felt previously unsolvable or intractable that you think now is possible?
Yeah, we're still too manual, right? We're still way too manual in the work we have to do in order to help patients. That's got to change, and I think AI does have the ability to do that. I think about even the glimpses of what we're seeing right now, Aaron, with being able to do a pre-visit plan, have it go check into non-coded data, bring it back and say that a care gap exists, send a text message to a patient saying, hey, you need to get that mammogram done, have them click it, schedule the mammogram, and go get it done and have it loaded in the right place in the record without a human touching it.
It does sound like sorcery.
It sounds like sorcery, but it sounds like, oh, that's untouchable. You're never going to get there. That's not true, right? That is totally touchable. That is doable. And we need to do that across far more than just mammograms. And so as I look to the future of what we're trying to help, it's how do we offload our already burdened clinicians and have tech do what tech can do so that our clinicians are doing what only they can do. And I think that's what the next year or two looks like.
Thanks. And Krista?
Yeah, so I would echo many of the comments. I mean, I think there's almost a limitless, right? I mean, there's so many things that we could potentially address. And that coming from, we've made a lot of progress. We really invested in a lot of efficiency work last year, and made some tremendous progress around, claims processing and, some of those boring administrative things. But it's a struggle to hire. It's a struggle to retain. And so to the extent that you can have those things that only humans can do, right, be done by humans and let technology take care of some of the others, there's so many opportunities. The one that gets me the most excited, so aside from the vision that Dave just laid out, because I agree that it's eminently possible, right, that's going to be happening in the next year or two, is prior authorization. It is probably one of the most painful processes. It's not fun for plans. It's not fun for providers. But, I could see, a point there where too, you're like clicking a button and AI is going out there and grabbing the important and relevant clinical information to send it to the plan, which is then, reviewing it and auto approving, probably in many cases, and seamless in it happening potentially instantly, right? And having those that are easy decisions at least be kind of removed from people's minds, so we can again focus on those edge cases where you need a little bit more, data. They don't quite fit, the standard for whatever reason. And then really focusing the effort on those so we can get those folks that are more complicated care quickly and not have to lag, right, and go back and forth 6 times till you get all of the information you need. So that's the thing that gets me the most excited. And I really hope we can get there in the next 1 to 2 years. That would, really make me very, very happy. And I'm sure I'm not alone in thinking if we could address prior auth, it would be, a breath of fresh air.
You are not alone. Sarah, with that, should we turn it over to audience questions?
Absolutely. Thank you all so much for that presentation discussion. We do have time for a few audience questions. So the first one I have here is, can you talk about how your team measures and quantifies benefits?
Thanks. Krista, do you want to take that one first?
Sure, I can go first. I think it really does depend It goes back a little bit to what I said to start with, which is it depends on what your goal is. What are you trying to achieve with the implementation? Because that will often dictate how do you measure the value or the benefit that you expect to get. But typically there is some kind of a financial or ROI that you're looking at. There's whether it's staff savings, staff time, or enhanced revenue, or some other financial measure. Again, depending upon what you're doing with the technology. And then there's also, will it improve, staff satisfaction, right? Will it improve member satisfaction? Some maybe a little bit softer measures, but that are also can be important. And in some cases can be the sole reason why you're doing it. You might not have a financial return. So that would be sort of generally how we think about measuring and quantifying benefits.
And Dave?
Nothing to add. I think she nailed it. That's what I think we have to pay attention to and keep track of.
Sarah, what's next?
Yeah, nailed it, Krista. The next question from the audience is, what foundations do you think need to be in place before bringing in AI?
All right, who wants to take that one first?
Happy to take a stab, Krista, and by all means chime in. I think there are maybe scenarios where a process has yet to be designed and you're using AI to create it from scratch. But I think more times than not, having a structure or a framework or a process that already exists and it is effective, it's just not efficient. Right. So I think those are kind of the things that I would say need to be in place before we're going to deploy the tech. At least that's the low hanging fruit. I think there will be stuff that hasn't even been thought of yet that we'll think through and say, well, gosh, I'm not even going to try and put that process in with a human to start when I know that AI is good enough to do that right off the bat. Let's just start with that. But I think there's fewer of those, and especially as we try and swim upstream, with the various EMRs we work with, and they're doing the best they can, but again, just not designed for what we're talking about. We are doing those processes today, and those are probably the most easy to convert into AI RPA type solutions.
Yeah, so I would definitely second that. You do not want to put automation on poor processes, right? It is good that you got to think about, is this process optimal before you put the technology on top of it. The second thing I would just add that I think is going to become more and more important is having a strong AI governance in place. I think, we have done some work there, and part of why we've done it is because we think it's helpful to be out in front of, any government regulation. We like to be in control of what we think is the best way to think about it. So that's another one. Again, I think that, not everyone is there, but I think it's something that folks should be thinking about as they're working to implement AI.
Well, I couldn't agree more with both of you around do not automate a broken process. Like something that is decentralized, done differently everywhere is probably not a great candidate for AI. So I think we're running short of time here, and so probably we'll wrap here. Krista, Dave, thank you so much. Always fun chatting with you both. And I think the audience will have learned a lot from this conversation. So thanks again for spending time with us.
Thank you for having me.
Thank you.